to the committee, to this wonderful initiative, and also thanks to Federico Nicolosi for inviting me to have this webinar. The title is quite explain quite good what I'm trying to say. Surgery in a CP angle is complex because there are many reasons for that. Because first of all, it's a very complex region from an anatomical point of view. The morphology is strange. The anatomy is complex. There is a restricted working area. There is a very rich number of vascular neural vital structures. And the other point, in my view, is that indication for surgery and for the choice of the approach are very difficult. There is no guidelines or study or RCT study, and factors which determine the choice of the approach are numerous and various. I think that in modern neurosurgical strategy, you should put together many different points and to find the good balance between good, of course, resection, but also respecting quality of life and avoid complication at the maximum. Sometimes the question is, but what is an optimal resection? Optimal resection is not always total resection. It's easier for a surgeon to go there and to pull out everything you see instead of be respectful for the patient and for the vital structures. Factors implicated are, as I told you, many, and some are patient-related, some are tumor-related, and maybe the most difficult are surgeon-related factors. As you know very well, I will go through things that are simple sometimes, and maybe for someone, and sometimes maybe it could be a little bit more difficult for older, maybe for the younger. But I think that the real scope is to stimulate reflection about some problem. Patient-related factors are age, global condition, symptoms. Maybe the patient is very symptomatic. And first of all, the goal of surgery, based on a suspected biology of the tumor. For example, is there the possibility after surgery to integrate with other strategies like, for example, radiosurgery for that specific patient, that specific pathology? Tumor factors, yes, are very important. The sites, of course, the exact location, where is the epicenter of the tumor exactly? Which is the extension of the tumor, in which direction it goes? Is there edema around the brain? So the brainstem is edematous, cerebellar peduncles, all the rest. And is there a good brain-tumor interface? And eventually, if the patient has been already operated or irradiated, so all these factors are extremely important to take into account. Surgeon-related factors are maybe more bizarre sometimes because depends on the personality of the surgeon and the experience of the surgeon in that specific pathology, in that specific approach. Maybe one of the most important points before doing surgery in that region is that possibility to have a multidisciplinary discussion in 2018 in order to understand exactly which is the path that the patient has to follow to treat his pathology in a modern fashion. What I try to do is go through an approach-based anatomy that is trying to understand clearly which is the anatomy of the region we are operating through. And this said, we must admit that the most important part for us is to understand the three-dimensional anatomy, to pass from a 2D vision of the anatomy, which is the vision we have from the books, from the pictures, to reconstruct into our mind the three-dimensional anatomy. It's not obvious. This mechanism is not obvious. And as well, it's not obvious to imagine and to be confident with every single structure being located in that area during that approach. But this is very important. And the other point is that we have to know very deeply the approaches and the anatomy of that approach in order to create, sometimes maybe maybe just from ourselves, from our effort, little variants of that approach without being excessively destructive to exploit that approach at maximum. As I told you, the hardest part, three-dimensional anatomy, this is fundamental because it has implications in understanding the approach, of course, but also in positioning. Many of you maybe are resident, and sometimes the chief or the senior tell you, no, you have to turn the head a little more, you have to bend the neck, because otherwise I cannot operate, etc. Yeah, there is a rational idea behind that, of course. One of the most important points today nowadays is understanding imaging before surgery. You have to exploit every kind of imaging, CT, MRI, CT angiography, everything. You can get important information from every single of these images. For example, MRI today is very powerful thanks to some sequences like CISS. Just look at that. You can see with this tumor, you can describe very well all the content of the internal auditory canal. You can see very well the tumor-brain interface. In that case, where you see how the tumor is attached and push forward the fifth nerve. Can I just ask Hamed if you can turn down the microphone, because I have some noise in my ear. Could you? There is some feedback. Yeah, perfect. Thank you. So, and the importance of the imaging is always to understand once again where is that tumor, and how the anatomy is deformed. Here I show you always tumors of the CP angle, but all these tumors are completely different, because this is just an example. This is the famous de Georges-Cerquer classification of meningiomas of the petrous bone. You know very well that A is in front of the auditory canal, M is on the auditory canal, centered on and this is posterior. These are three different tumors with different strategy, approach, and mostly different outcomes. And that's the point that we are all interested in. Another important point is to have clear in your mind references. It's not enough to say this is a posterior petrous bone tumor or anterior petrous. You have to have references, exactly how. In the same way, when you walk in a countryside, you see a dead tree or you see a church or anything else. You have to have references. So if you want to express that the tumor is more cranial, you will see that it's above the tuberculum jugularis, or if it's more toward the middle clivus, or if it's medial to the internal auditory canal or medial to the trigeminal nerve. So always define the position of the tumor correctly and specifically, because this changes everything. And of course, I'm telling this based on imaging. If we pass to talk about approaches, we can classify two big and two wide classes: the posterior approaches to the CP angle and the lateral approaches to the CP angle. If you see these two concepts, basilar concept, the first thing you note is that posterior approaches are posterior to the sigmoid sinus, so the sigmoid sinus stands anteriorly, and the lateral stands, the sigmoid sinus stands posteriorly, and that's it every time. So every time you pass laterally, you will have sigmoid sinus posteriorly. This is something that may be obvious, but this will have implication for the future, as I show you. And when we talk about lateral roots, it's all about petrous bone anatomy. What does it mean? This means that you must know the anatomy of the temporal bone, and specifically of the pyramid, that is the petrous bone. And of course, everything is from posterior, and from the classical retrosigmoid, the neurosurgical approach, I would say, it's just all about cisterns, cisterns, and cisterns. This means that everything is in this area you must know very well. One of the concepts is that CP angle is a cisternal space. It's not an anatomical test. If you talk to a basic anatomic professor, probably they do not know the cerebellopontine angle. This is something that is surgical definition. This space resembles a truncated pyramid that I will show you soon. And of course, it has boundaries. There are medial boundaries, the pons. Inferiorly, there is the brainstem with the bulb and the arachnoid of the lower cranial nerves. So the lower cranial nerves represent the inferior border. Superiorly, there is the middle cerebellar peduncle and the tentorium, of course. Laterally, there is the petrous bone, and posteriorly, cerebellar hemisphere. So this is this truncated pyramid. And so this is the CP angle, okay? I just want to go rapidly through the basic anatomy, because I suspect that you know very well this anatomy, but this is just to show you the importance to understand which cistern I'm passing through to go to that target. So mainly the CP angle is formed by three cisterns, which are cerebellopontine cistern, the cerebellomedullary cistern, and the cisterna magna. Of course, there is some overlapping passage, like the prepontine cistern, and then premedullary cisterns as well. This is how we see it. We stare at these cisterns through MRI. This is the cisterna magna. When one of the most important things is that when you think to a cistern, in your mind should pop up the structure that are in that cistern. So cisterna magna, tonsils, pica, foramen of Magendie. That is the outlet of the fourth ventricle. At least these three structures you have to think to immediately when you think to cisterna magna. As well, if you think to the cerebellomedullary cistern, which is the lower part of the CP angle, like a pop-up, you see that lower cranial nerves, medullary veins, origin of pica, and sometimes vertebral artery. You know very well that artery like that, vertebral artery and the origin of the pica, can vary a lot. And as well, the cerebellopontine cistern, PUF, is the cistern of 7th, 8th, and 5th nerve. And of course, of Dandy vein and mesencephalic vein. Then the trigeminal nerve is on another MRI cut, is upper, as you can see here and here. This is you see very well the rootlets of the fifth going through the Meckel scale. Now, talk about three-dimensional anatomy, because that's the point. I put this image of the skull, not because it's very nice, but I'd like to call your attention at the fact that the petrous bone, laterally, of course they are specular, has a peculiar direction. And as well, the CP cisterns and the CP angle has exactly the same anatomy, which is, it's like a triangle going from back, forth, and down, up. So it's something that goes in that direction. This is extremely important to realize, because every time you want to go to a target, and you know where you start, for example, retrosigmoid, you have to realize that if you pass through a retrosigmoid and you want to go there, you have to go up, okay, like a stairs. To show you that, these images are also very, very good, because they show you how, when you pass once again from back to the from a retrosigmoid approach, you must go up as long as you want to go further and to go to the midline. This is a classical image that explains once again this point. To clarify that, I created this simple grid that, and I just depicted lower cranial nerves, 7, 8, and the 5th, okay? As you can see here, these 3 nerves are on, not only on different coronal plane, so from back forth, but also on different axial plane. And this show you very nicely that if you come from here and you want to go here, you have to realize that they are on different plane. Just simple video of dissection of a CP angle cistern. This is, I will show you almost always left-sided approaches, and I will tell you which is the position of the patient. This is a retrosigmoid approach through in a park bench position. Yeah, the most important point that at the center of a good retrosigmoid approach, there is the 7/8. And you can realize very soon that the 5th nerve is deeper and is in front of the 7/8. So to reach this, you have somehow to, if you want to go here and to make the 5th at the center of your microscope, you have to move your microscope to go there. So I know these are simple when you say that, but when you are there operating, you have to realize that. Look at that. Now I want to see the lower cranial nerves and the perimedullary cistern. I have to move my microscope down here, and you will see the section of the section of the arachnoid. Sorry, just to go a little bit faster, and you will see the lower cranial nerve appearing here. And this is another plane. This is more superficial and posterior. Okay, so this is just to give you the concept. To reinforce this concept, this is an endoscopic view at the end of the resection of a kyst in the cerebellopontine angle. You have here, this is the same position, the same approach. This is the tentorium, vein of Dandy. This is the 5th cranial nerve going into the Meckel's cave. So here is the apex of the petrous bone. You see the ICA, you see the 7/8. You see how they are on two different planes, and then you see the lower cranial nerves in another more posterior and inferior position. So another point is that always, once you have completely understood the anatomy of a CP angle, you have to realize also that you can of course, reach many targets which are not exactly on your route. I mean, just by rotating the microscope or dissecting your arachnoid, you can go further. You can go much further than you expected. So that's important because, and then I use this image that I constructed to show you exactly this idea. This is a retrosigmoid corridor. And this is the famous far lateral approach corridor. You see that in many points, they are overlapped. And this is typical in neurosurgery. And why I show you this? I show you this because if you have a pathology in that, I would say, shared field, you cannot necessarily do a larger approach. You just dissect and you just can work in this space, which is part of the far lateral approach. Or, for example, you can resect more the bone inferior of the retrosigmoid, and you can go at the top of the jugular tubercle. Veins anatomy. The anatomy of the veins of posterior fossa is extremely complex, but and I cannot go through all the anatomy, of course, but I want to draw your attention about which are the most important veins in the related to the approaches, which are the superior petrosal approach, inferior petrosal approach, which pass in the petroclival fissure, which is the fissure between the petrous bone and the sorry, and the lower clivus, and the retrosigmoid, and the sigmoid sinus. Talking about posterior approach, well, the only one concerned is the sigmoid sinus. Sigmoid sinus, why? Because it's a very important sinus and you have to respect it. Sometimes you can, while you're drilling the bone, you can create some tearing. So this is the only thing you have to know is the correct position, and we will see soon after. Whereas when we talk about lateral approaches, your sinuses are the superior and inferior petrosal sinuses. And let's start to pass through the approaches. Lateral approaches, of course, I will talk about the most famous, the most used, which is the translabyrinthine approach. Of course, there are some variation. As I told you, you have to learn and to study variation to understand how to exploit at maximum approaches. The most important are the sigmoid approach and the combined petrosal. But let's start from translabyrinthine approach because it's the most famous and used. The 3D anatomy of this approach is basically the 3D anatomy of the petrous bone. These are three projections of the petrous bone. Once again, I cannot go through a minimal anatomical study of the bone because otherwise we should need the entire day. But I want to draw your attention about the importance when you talk about a trans-temporal approach to know the anatomy of the internal auditory canal. So through the cuts of a CT scan and the body and the bony windows here, you can see the anatomy very well. But once again, this is just a 2D image. If you use such an image in transparency, you soon realize something which is not exactly something that you see and you realize very soon. The first thing is that you can see here the internal auditory canal, external auditory canal, and carotid canal. What you can see here is that first, internal, external auditory canal are almost on the same line. This is very important to understand. The other point is that I'll put here these shaded areas just to emphasize anatomy, and I put this purple area to just to let you know where the labyrinthine block is placed in the three-dimensional anatomy. And this is the reconstruction of the internal anatomy of the bone, of the petrous bone, with a nerve, which is the seventh nerve passing through the internal auditory canal. These are the knees of the facial nerve, and wonderfully you can see the block of the labyrinthine here, and the cochlea here, and the ossiculi here, and the tympanic membrane. What I would like you to extract from this image is that all the approaches from that way toward the internal auditory canal, and when you want to pass to the internal auditory canal, you have to remove that. So this is your limit to the internal auditory canal, and also the position of the nerve here, which is exactly at very close to the external auditory canal, as I show you soon. I constructed this image and I overlaid these areas just to show you that in normal position, in a normal patient, the sigmoid sinus is just back to the area where you operate to do a translabyrinthine approach. This is the green area is the area of the mastoidectomy. because these are the first step is a mastoidectomy to do a translabyrinthine approach. This is a normal auto surgical approaches. So the patient is in lateral position with the head turned. The green area is the mastoidectomy. The purple is the labyrinthine. And then you see that just once you have removed the labyrinth, you can see the internal auditory canal. This is an anatomical view. And just to confirm what I tell you, posteriorly, so we are always on the left side, posteriorly you have your sigmoid sinus, middle fossa, semicircular canals, labyrinthine block. You see here your fallopian canal. This is the external auditory canal, and this is the antrum. Let's see intraoperatively. This is at the end of the surgery, or at best of the approach. You see your sigmoid sinus, antrum, fallopian canal, internal auditory canal, middle fossa. And this is at the end of surgery. You see your facial nerve here, and you realize, well, that this kind of approach gives you the excellent and rapid control of the facial nerve, because you take your facial nerve exactly into the internal auditory canal. So the advantage is that you see at the end that you control the nerve beautifully, and you manipulate very, very in a very light fashion the cerebellum. Once again, these are post-operative approaches, and you see the CT scan post-op. If you compare to the healthy side, you see here semicircular canals and the cochlea and the internal auditory canal. You see here the internal auditory canal is completely open. You see the cochlea here, you don't see the semicircular canal. Once again, another control, and you see here two-dimensional vision of the approach. Let's see, this kind of approach, if you reflect on it, if you see, for example, this image, the canal, the corridor toward through the translabyrinthine approach is a bony corridor, completely bony corridor. And this is very important because, of course, as all the other approaches, you have limits. These are bony limits. This means what? If I want to go more medial, up or below, this equates to the fact that I have to remove more bone. Let's look at this case of an horrible petroclival tumor. You see that if I want to go here, so you're more medial, from a translabyrinthine approach, you see here, this is a beautiful image from Jackler. You see how transcochlear approach is needed to go more medial. And I show you this image of a cadaver. You see, this is what we was just seeing. This is a translabyrinthine approach. This is the petrous, complete elimination of the petrous bone with exposure of the internal carotid artery, of the whole facial nerve. And you see that with this, you can expose more. Of course, we're talking about a very complex approach, time-consuming, risky, because you have to move the facial nerve. So we're talking about something that is not everyday surgery, or at least the surgeon must be very trained for that kind of approach. And you see how to go, if you have a translabyrinthine approach that I just show you, your area of approach is this. But if you have to go more toward the apex or more medial, you have to do this. You have to completely drill flat the entire petrous bone. Once again, if I want to go up, so I want to do a trans-petrous approach, but I must go upper. What I have to do? In that case, normal, I would say, a standard trans-petrous is not enough. That's why combined Petrosal approach have been designed to satisfy the need to go upper. Why? Because the combined Petrosal approach are nothing but combination of a lateral approach to the posterior fossa and a middle fossa approach. This plus this give you the possibility to go higher. Just very quickly, the steps of this approach is an approach in which you can respect the labyrinth because you do a retrolabyrinthine approach, but you have to retract the temporal bone and you have to do what is a middle fossa approach, that is recognize V3, as you can see here. I put this red flag. Then you have to remove the bone between V3 and the internal auditory canal. So you have to do a Cavazzi approach, nothing more than this. And then you have to open completely the tentorium, the dura of the middle fossa, the dura of the posterior fossa, close your superior petrosal sinus, and this is the vision you will have after this complex approach. This is a very time-consuming. Sometimes these approaches are performed with first-day approaches and the second-day tumor removal. Of course, when you choose such an approach, I suspect that the volume of the tumor is something like that, because I really do not advise to do such an aggressive surgery to remove little tumors. Or at least I hope so. A pass to the more standard neurosurgical approach, like posterior approach, having in mind always an anatomy, an approach centered anatomy. Retrosigmoid approach is a classical approach, is very famous approach. We can call it Asterional approach, just to recall terminal approach. Why? Because the key hole is the Asterion here. So the hole on the Asterion is the first step. As you may know, Asterion correspond to the passage from the transverse sinus to the sigmoid sinus, but it's not always like that. So if you can use also neuronavigation to have the certainty that the hole falls exactly in this point. I don't want to be too meticulous in showing off this approach, but there is some point that is extremely important. You do your first hole here, burrow here, but first you have to recognize some important structure, like the mastoid tip, the gastric groove. Why? Because as you can see here, the gastric groove leads you to the line passing from the sigmoid sinus. So if you recognize bony anatomy, you can have a very good approximation of the internal anatomy. But once again, you do your burr hole and you perform your craniotomy, craniectomy, whatever it is. During such an approach, in my opinion, at least, it's not important how large it is, or at least you do not have to do largest craniotomy, because your point of your area of work is here. So the very important point is the drilling of above the sinus, here and here, because this is your entry point. So you must see at least 1/3 of the sinuses. You know why? Because if you leave too much bony behind, you will have to retract the brain. Whereas if you are meticulous in exposing the sinus, you can go down without any kind of retraction. Another important point is not to leave bone onto the sigmoid sinus, because this point is exactly the point where you will enter first to open the medullary, the cerebellomedullary cisterns and have your CSF outflow. I show you this video because it's important to realize that this is always park bench, left park bench surgery. You see here your schwannomas, quite large tumor. You see cerebellum is not, I would say, it's not calm, it's not quiet, tend to get back and to cover the tumor. This is why, because you have not still open this cistern here. And you will see here that once you open this, the CSF come out and everything will be calm, quiet, the cerebellum will fall, and this will give you the possibility to work and to dissect your cistern very, very well. You see this, okay, you see the CSF coming out. The most important thing to realize is that retrosigmoid approach, differently from the lateral approach, which are always the same position, you can do this approach through different position. And position can help you in an enormous way because you can totally change perspective. And so you can go toward targets which you did not expect it. So you can do a retrosigmoid approach through a semi-sitting position or to a park bench position. I will show you how I use one or other, with which kind of indication. The park bench position is that, you see this, the red ring is the approach, this is the light of the microscope, just to show you that when you put a patient in a park bench position, your microscope has this direction. Okay, you cannot work perpendicular to the air, but you have to be a little bit from the down to top. In a sitting position, you have to always to rotate the head of the patient on the side of the tumor, and you have to bend the head anteriorly. This is fundamental because in that way you will take the most anterior and superior structure to fall, and so you will control the farthest part of the CP angle very easily. Once again, this is the same concept. You see, once again, this direction, but if you tilt anteriorly the face of the patient, you will have this straight, direct way toward the petrous apex. As you may know, semi-sitting position has some drawbacks and some fantastic characteristic. Excellent venous outflow, unique intracranial shrinkage of structure because there is no pressure in the posterior fossa. Air embolism risk, yes. There is a risk also for surgical hematoma because once the patient is put in supine position, there could be some venous infarction. But when you have tumors that go very, very high toward, for example, incisura tentori or beyond, or are premiatal or medial and are large and very vascularized, in this position, you will work beautifully. I show you just some case like that. This is a quite large meningioma that go, as you once again understand the anatomy. You see, this is the incisura tentori, so the tentorial notch, and the tumor is beyond the tentorial notch. So the tumor comes in contact with the posterior clinoid. This is at the end of resection, an endoscopic exploration. It's very useful for me to show to residents to understand anatomy. You see at the end of resection, this is an endoscopic view. You see the tumor is out, but you see this is in a semi-sitting position, left side. You see the pons, you see the clivus, the third cranial nerve, posterior cerebral artery, SCA. So you control everything from this position. The head is flexed anteriorly, and that's the point, and then rotated to the same side. And what you can see here also is how nerves are spared very good here in the fifth, and then going back once again, the 7 and the 8. This is the control, this is the post-operative control with a total removal. As I told you, with minimal variation of approaches, you can have much more. And this is the case of drilling the supramiatal tubercle. Supramiatal tubercle, not in all patients, but in some patients, is very, it's a very important bony structure which is in your field and obstruct your vision of the Petrosal apex and of the Meckel scale. So you can drill down, drill flat this part, and you can go very far like that. This is always a semi-sitting position. This time is right side the craniotomy. You see how to drill the supra-miatal tubercle. And you see another case at the end of resection. You see there is no more bone here, and you can go further and explore the part of the meningioma invading the cavernous sinus here, and remove what you retain possible. Once again, the third cranial nerve, the tentorial notch, and the fifth cranial nerve. I'll go through this control. You see the complete resection with the little residue here. That once again, a young patient, no deficits, and so I personally prefer to leave some little tiny tumor here. And to show you which is the direction when you perform the suprameatal resection, look at this tumor. This is a fifth nerve schwannoma, and you see the complete resection. You see exactly where once you do your suprameatal, you can go toward the Meckel scale and the internal cavernous sinus part you can remove. Once again, we leave something here because not to put the patient at risk. Maybe with an endoscope assisted surgery, we should have more. We could have removed more tumor, but that's the point. What about the internal auditory canal? Yes, from this side we can control just a part of the of the internal carotid canal. But as shown by many authors, you can open it and you can remove the tumor respecting the nerve, the facial nerve. This is a technique. I go rapidly through that. Don't want to steal your time. And you see here the exploration. You see the nerve into the canal, and then you will see the, the section of the tumor and of the nerve here, nerve and tumor. Just for the unbelievers or for those who do not love semi-sitting position, I'm now operating more and more in this modified three-quart prone position that so just for kidding, I call it Dormeuse position because it is a famous picture. The idea is to mix together the advantages of the three-quarter position, the park bench position, and the semi-sitting position by putting the patient of his side, but with the extremely high level of the thorax. In that way, we can assure a very good drainage of CSF and venous blood. And in this way, we are having wonderful fields, very posterior fossa is with very low pressure inside. Sorry, I think that, okay. Just to try to conclude, general management of this, in this area, we, of course, as many centers, we operate mainly vestibular schwannomas and meningiomas. And nowadays, maybe, at least in Italy, there is no a large consensus about operating on lethal surgery, lethal tumors. So we mainly operate large, compressive, symptomatic lesions, okay? And of course, this is because in Italy, there are excellent radiosurgeons, radiosurgery, and radiosurgical centers. So we must confront with them, we must discuss always for the benefit of the patient. Sometimes we operate on smaller lesions because sometimes radiosurgeons say that no, it's better you take it out rather than irradiate. This is the case, very briefly, where this is a schwannoma where you can do surgery by retrosigmoid approach, and you can respect not only the seventh nerve, but you can save the earring. So it's possible to save the earring. When use one on another? Well, the point for me is that once there was a time where discussion was about respecting the hearing. So nowadays, as we operate large tumor, the hearing function is not more a question, it's more an issue. So I personally prefer to go through sigmoid sinus. Yes, patients, colleague says also labyrinthine is a very nice options. But as I show you, a retrosigmoid approach in a good position, which is semi-sitting on 3/4 dormeuse position, may give you the possibility to go everywhere in the CP angle. And always use neurophysiological monitoring, of course. And of course, you have to master at least translabyrinthine approach with the help of ENT surgeon, and to understand that in our mind, when the tumor completely fill the internal auditory canal, translabyrinthine approach is a very good option. Or, for example, when there are elderly patients, or where there have been also a previous retrosigmoid approach. At the end, okay. At the end, in large tumor, consider always to leave some residue of tumor. Be wise and reflect about the quality of life of a young patient like that. This is a typical situation where you will find your seventh nerve, which is totally stuck with the tumor, and you leave pieces of tumor instead of destroying the nerve forever. Talking about approaches and ending up, I think this is my personal opinion. I want to tell you, this is my personal opinion. First thing to do is to learn basic approaches like retrosigmoid approach, neurosurgical approach to perfection. You must know everything and be total confident to anatomy of that region. Try not to change continuously approaches to be, I would say, to be to follow fashions and to see what's going on today. No, first use the simple approaches and apprehend this approach at maximum. If possible, avoid approach-related pathology, and if you need it, use multi-stage approaches or use multimodal approaches through radiosurgery. Remember that there are many studies that residue of tumor can sleep for years, and so you can take your time, and if you will have some relapse, you will treat with radiosurgery. So I finish here, and I'm totally at your, and I'm totally yeah. Ahmed, hi.
Thank you.
I can't hear you.
Okay, thank you very much.
No, I can't hear you. You have to turn.
Thank you very much, doctor. You can hear me now? Can you hear me? Can you hear me?
Privately turn on the mic. Thank you.
So there is question, I think here. Thank you to Spain for the navigation. Thank you. Can I ask Mr. Spain for reference he advised to master CPM? Yeah, that's very good.
Can you hear me?
Can you hear me?
I can hear you.
You can, huh? Doctor?
Just to answer to Nashadin Mohammed, I think that for references in books, there are many. But one of the most important things is to comprehend the anatomy of CP angle from different sides, from different point of view. So you should ever study on neurosurgical books and on ENT surgery books. You cannot only see the from just one side of the story. So just from the neurosurgical perspective or from auto-neurosurgical perspective. So you must comprehend lateral and retro sigmoid approaches, and this will give you a very good vision of the problem. And yeah, the lateral approach, I want to advise you with Mario Sanna, our one of the most important Italian autosurgeon, and Mario Sanna did I think 2 or 3 books that were extremely important in explaining surgery of the lateral approaches. Regarding retrosigmoid approach, everything coming from SAMI is of course it's extremely high level, also from the school, from Tübingen, Professor Tatajiba. And also you can start by studying the atlas or anatomical surgical atlas from Koos and Spetzler. So there are, frankly, there are many books from start with. The advice is to, of course, study a lot, but you have to train to practice first in cadaver labs, and to try every single approaches. And so it's about quite a long way. If you love this surgery, this kind of surgery, you have to start to start very early. So when you are a resident, if you are in love with that, you start by accumulating information, and then year by year, you will practice very. It's a long and it's a long and slow run. So I cannot say that yes, tomorrow you do your best, but in some years you can do if you start very soon. The approach which is completely bone is the lateral approaches. So translabyrinthine, retrolabyrinthine are all or bony approach. May you kindly repeat the importance of the the gastric groove is the groove where you find your I will show you that. I will show you that because
لا هو واحد سألوه هو راجع
I will show you that. Okay. Just to answer to Serge Eddy Mba, the gastric groove here, if you compare this line passing to the gastric, you will see that it is always it's also the line of the sigmoid sinus. So you know that these are on the same plane, and this is very nice. It is a very good. This is a very good reference. I'm just reading about what suggested to youngsters who change to reach. Federico asked what suggestion to youngsters which aim to treat CP angle tumors. I think that there are 2 aspects of the problem, and this apply for all difficult surgery. First you apprehend everything about that pathology. So you must comprehend the evolution of a meningioma, the natural history of a schwannoma, which is epidermolysis. So everything about the natural history pathologies, how is a patient with this pathology. And then you follow surgeon that does this kind of surgery. You spend time in anatomy lab, you spend time in surgery, in surgical theater, and then the other point when you're very young is to see the outcomes of the patient. So follow ambulatory controls to see exactly which are the outcomes. You have to have clear in mind how is to harbor such a tumor and how is to be operated on for this tumor. This is the first part of the story. Then, of course, you have to train. I think that a very good point to start is when the senior surgery will do, as I show you, will do, for example, a Janet approach for a microvascular decompression. You should beg, or you should be lucky and let you explore the anatomy of the cistern, move the microscope, move the muscle around like when you are in a museum, see every wall, see every pictures on the walls, everything, and always understand where you are pointing to and how much you have moved your microscope, how much is the inclination, everything. This is all about three-dimensional anatomy. And of course, we think with Federico as well, that the importance of having three-dimensional anatomy and also navigable anatomy, so something that you can explore, is very important for the brain of the user, of the student, of the resident, to understand this anatomy. If you do not, you are not if you're not confident with this kind of anatomy, this will be hard to go further. Yeah. Okay, there is asked, what was it? Okay, let's see. Yeah, what was the, let's see the second slide. Okay. No, I think he was like talking about that. What is the answer for the case on the top left? Okay, this was a meningioma. It was just a meningioma. I was also surprised to see this strange, I would say, tiger-like coloration, but was just a funny necrosis inside the tumor. So nothing strange, actually.
It is a meningioma, huh?
I lost.
So that case was a meningioma, the one on the top?
I don't know why I can't. I can't hear Ahmed no more. So,
Doctor? Excuse me, doctor?
Looks like no matter how you master this zone, still
So he said it was a meningioma,
right? Doctor?
Gian Antonio?
Hello, Dr. Federico.
Hi, good morning. Good evening.
Yeah, any suggestion for internal auditory canal drilling? Yes. Let's see.
It was necrotic from inside.
I think there is a very important point is that you have the possibility to use new tools for bone drilling, like a piezoelectric or like sonobet, like something like that, you can do your bone drilling with extremely low risk. But if you use usual drill, so if you use bar drill, like diamond bar drill, I think that one point could be very useful to you. Do not use too much tiny drills. If you measure your internal auditory canal and your area to drill, I'll show you what I'm saying.
Thank you very much, doctor. Can you hear me?
If you okay, if you measure this distance from here to here, and you find that about normally it's about 4, 5, 6 millimeters, use a bone drill about 4, 5 millimeters, not a tiny drill, because in that way you can put your here. You do a little hole here, and then you can push you like going in that direction and that direction. And in that way, I think the risks are reduced. Whereas if you use a tiny drill, you can risk to go into the canal, and more if you use a 4 millimeters, you have already the maximum diameter you have to drill down. If you use 1 millimeters, you risk to go a little bit more here or here, and you risk for destroying the semicircular canal.
Can you hear me,
This is a very
doctor?
interesting point from Zimbabwe. The basic instrument needed to do a CP tumor. I think that it's hard to answer to this question because, of course, this is a costly surgery. You need neurophysiology, etc. But for the fish, if your scope, if your goal is to save the nerve and to do respectful surgery, you should have at least a monitoring of the facial nerve. If you don't have this, I think that you can do also partial surgery, not radical surgery. And for example, if it's schwannoma, meningioma, you can remove the maximum part. But without microscope, I think it's quite impossible to do this surgery. So with a microscope, you should just a burr hole and the craniotomy, and then you need micro scissors, bipolar forceps of different length, and of course your retractors, because at the beginning it's not so easy not to use brain retractors. So I think to have a good results and to at least decompress the tumor and probably just to make the patient, to eliminate the risk for the patient to die for the tumor and for a schwannoma. And so your goal would be that of decompressing the tumor. I think that you don't need 150 different instruments to do this surgery. Yeah, this is a very good question, how to separate tumor given to brainstem. That's a main point. Unfortunately, today we do not have certainty about preview, which is the degree of the adherence of the tumor to the brainstem. This said, there is, of course, the sensitivity of the surgeon and in your eyes at the microscope. When you are there, you start dissecting, but if you see that there are veins, brainstem veins, which are totally adherent, and I would say they are encapsulated into the membrane and in the capsule of the tumor, well, this is very dangerous. you remember that when the arachnoid plane, when the dissection plane between the tumor and the brainstem is not present, you cannot find it, the patient will have great problem, mostly because you have closed veins. So most part of the problems are related to infarction. If you do not feel that the plane is good, and how is good, you have to see that when you remove the tumor, you see the pia mater of the brainstem. If you see the pia mater and you see that it's just about separating and not penetrating, if you don't see this separation, stop, just remove the tumor, intracapsular removal, and do not touch the vein, because otherwise the risks are extremely high. In my experience, I had one patient dying for schwannoma, a very large schwannoma. It was a kystic schwannoma. It was about 5 centimeters, multiple kysts. Kysts can be very disappointing because kysts are a strange behavior. They fuse with the pia mater of the brainstem. You cannot separate it, and when you want to do that and you try to separate this material from the veins and from the pia of the brainstem, you realize that you are not creating this dissection plane, but you are entering the subpial plane, and this is extremely dangerous. And what happens was exactly that. Was an infarction, a venous infarction. Was extremely disappointing, but unfortunately, it was also an horrible tumor. So starting from that experience, of course, I tried to do my best to find this dissection plan, but if I cannot, I do not insist too much. This is typically a problem with largest tumor. The other point is that if you suspect on MRI T2 or MRI T2 sequences that there is edema in the brainstem, this can be a good indication that maybe the dissection plan has been lost. So you have to be particularly attentive.
Thank you, Gian Antonio. Do you hear me?
So I don't know if we have more time or
Gian Antonio?
Just a minute, tell me.
Do you hear me, Gian
Write
Antonio?
down something.
Gian Antonio, do you hear me?
Hi, doctor.
Yeah.
Finally, we have a technical that's in hearing you. And
to identify the dissection plan, you have to imagine that if you have experience in operating on meningiomas of the convexity, you have always seen that there are good meningiomas. They have their arachnoid around, so you have basically just to debulk the tumor and then separate with your cottonoids on your dissectors the tumor from the arachnoid of the brain, or maybe from the pia. Well, this is a good dissection plan. The point is that sometimes when you remove a simple meningioma, edematous meningioma on the MRI T2, you see that meningioma has passed the arachnoid, the pia, and it is practically intracerebral. That's the point. This is the point where the tumor has completely become intracerebral. It's clear that when you are operating on a convexity frontal meningioma, this is not an issue. You can remove it very, I would say, without problem. But if this plan is this trespassing of the plan is in the brainstem. That's the point where you have to stop absolutely. You cannot remove any kind of benign tumor adherent to the brainstem, which has passed the PIA without severe problem. So this could be the response to your question. Search for PIA mater and arachnoid. If you don't find that, and if you see that the brainstem is exposed, I'm talking about the white matter, exactly like a meningioma, the convexity, you have to stop. There are no much more conditions. There's no easy to find many other technique to detect this situation. It's all about experience, of course, but if you do this comparison with the supratentorial tumors, meningiomas report this idea of trespassing arachnoid and PIA, you will find that in the posterior fossa it's quite the same, and this could be useful to you to recognize this situation. Avoid cerebellar retraction in comparing the classical. Yes. The dormeuse position I use, yes, I normally do not use brain retractor neither during park bed position, but in this position, dormeuse position, the advantage is that you can go much more easily toward the tentorial notch, the petrous apex, so toward the clivus, exactly like the same sitting position. As I changed the hospital, the reason is that as I changed my hospital, I was first in Brescia, now I'm in Lecco. Anesthesiologists here are quite about doing a semi-sitting position. So I started to think about how to take advantage of the position. And so we changed in favor of this position. And I can tell you that the visibility and the maneuverability of this position is excellent. You don't need at all any retraction.
Thank you, Gian Antonio. Do you hear me? Gian Antonio, do you?
Dr. Federico, do you hear me?
Yeah, I hear you.
Yeah, I think the problem of connection with Dr. Gian Antonio.
Do you hear me, Amro?
Yes, I can hear you. We took already 18 minutes over the predicted time, so
Okay.
I think we should thank
Say
Dr.
goodbye to Dr. Gian Antonio.
Thank you
Gian
very
Antonio.
much. It's a great job, and we'd like to invite you again later on.
Okay.
I know there's nothing we can do, but maybe next time we'll talk.
Okay. Yeah. Thank you, Dr. Gian Antonio. Thank you to Young Neurosurgeons Committee. And Amro, do you hear me?
Yes, I can hear you.
Amro. Okay.
Yes.
I only can say something about Gian Antonio. I think Gian Antonio.
Everyone, I want to thank. Unfortunately, there is some problem with the mic with Ahmed. I think that if there is no other question, no, there is once. We routinely use supine position with head turn. Any points regarding? I do not love this position because I have always found problem in those patients who are maybe fat people or with like me, like a short neck. This is not wonderful to see that you have quite important compression of the jugular veins, and so you have, especially when you have large tumors, you can have a very stuffed posterior fossa, and I don't like that. My goal is to have a relaxed cerebellum. This is the point. You have to have a relaxed cerebellum, and when you have this, you are happy and you can dissect everything you want. So to have this, you have first take the best position of the patient and then dissect all the cistern and the cerebellum will fall. And that's my point. Dear friends, I'd like to say hello to everyone. I must go, and but I'm happy I completely at your disposition for anything. If you want to write me, to contact me, no problem. I will answer even by email. Okay. Thank you very much to the World Federation and to Federico and Ahmed. And I hope to see you maybe around the world in some congress, for I don't know, for the World Federation or even in other congress, or to come to Saudi Arabia to say hello to you. Okay.
Sure.
Best. Ciao.
Ciao.
Thank you very much, and thank you for the attendees. You can see the whole talk in our YouTube channel, and also you can see the previous webinars in our channel. Thank you very much, everyone.